Welcome back to Medical Review with Dr. H. Today, we are diving deep into cholesterol and statins. And you might think it's just all about chasing a number on a lab report, but the new thinking is so much smarter than that. It's really about pinpointing exactly who gets the most benefit from these powerful drugs. We're going to break down the evidence-based approach that's really changing the game in heart health. So let's get right into it.
Here's our game plan. We'll start with the big picture philosophy, the why. Then we'll get into the nitty-gritty of who actually needs a statin. We'll cover all the practical stuff like dosing and labs, what to do when side effects pop up, and of course, what our other options are beyond statins. And then we'll wrap it all up with a real-world clinical case to see it all in action.
So, let's kick things off with that new philosophy. The goal is actually pretty simple, but incredibly powerful. Get the right people on a statin. But to really get why this is so important, we got to do a quick refresher on the basics of cholesterol itself.
I love this analogy. Think of your arteries like highways. LDL, the bad cholesterol, is like a fleet of delivery trucks. They're dropping off cholesterol that your cells need, which is a good thing. But if you have way too many trucks, you get traffic jams, cargo spills, and those spills are the dangerous plaques. Then you have HDL, the good cholesterol. That's your cleanup crew. They come in, clear the debris off the highway, and haul that excess cholesterol back to the liver to be disposed of. It's all about that balance.
Okay, this next part, this is the absolute core of everything we're talking about today. If you take away just one thing, make it this. We're about to go through the 4 specific groups of people who, based on all the evidence, absolutely, positively, must be on a statin.
4. That's the number. You have to burn this number into your brain. Just 4 clear-cut groups. If you can spot a patient who fits into one of these 4 categories, you've pretty much mastered the most critical part of these guidelines.
So let's walk through them. Group 1 is the most obvious one. Anyone who's already had an event, a heart attack, a stroke, you name it. That's secondary prevention. Group 2 is for folks with just outrageously high LDL. We're talking over 190. It's so high, the risk is a given. Now, groups 3 and 4, this is primary prevention. They have moderately high LDL. So for group 3, if they're between 40 and 75 and they also have diabetes, boom, they're in. And for group 4, same age and LDL range, but maybe they don't have diabetes, but other things like smoking or high blood pressure jack up their 10-year risk score. They're in too.
And here is the single most important takeaway. For every single patient in those 4 groups, the goal isn't just any statin. It's a high-intensity statin. The evidence is just overwhelming that we need to be aggressive with treatment to get the maximum possible benefit. This is the standard of care, period. Okay, so we've figured out who needs a statin. Now let's get practical. Let's talk about the how-to. This is all about picking the right drug, the right dose, and making sure we get all the proper safety checks in place before we even start.
This slide right here is super high yield. You really only need to memorize 2 drugs and their high-intensity doses. Atorvastatin, 40 to 80 milligrams, and Rosuvastatin, 20 to 40. And here's the best part, a little trick. To get the moderate intensity doses, you just cut the high-intensity ones in half. So that's Atorvastatin 10-20 and Rosuvastatin 5-10. See? Super easy to remember.
Now, before a patient even swallows that first pill, we need some baseline numbers. A lipid panel, that's a given. A hemoglobin A1C is crucial to check if they belong in that diabetes group. And this is critical. We need a baseline creatine kinase, or CK, and liver function tests, or LFTs. Why? Because statins can sometimes affect the muscles in the liver, so we absolutely need to know where the patient is starting from.
All right, so we've done everything by the book, but then you get that phone call. The patient is having side effects. This is a really common hurdle, especially when it comes to muscle pain or funky liver labs. So let's talk about how to handle it.
This scenario comes up all the time, right? On your exams, in the clinic. You've got a patient who absolutely needs a statin for their risk, but the medication itself is causing a problem. So what do you do?
And the answer might actually surprise you a little. The main goal here is to try and keep them on a statin. The guidelines lay out this really clear 3-step process. First, you temporarily stop the medication. Second, you wait for their symptoms and their labs to go back to normal. And third, this is the key part, you restart the statin, but at a lower dose that they can hopefully tolerate better.
But what if even that lower dose doesn't work? For that small group of patients who just can't take a statin, period. Well, that's when we have to move on to our second-line agents. And this is another one of those areas that's super popular on exams. So let's do a quick review of the key players.
Let's do a little rapid fire. First up, fibrates. They're good for overall cholesterol, but here's the catch. They can also cause muscle and liver issues, just like statins, so we do not combine them. Next, ezetimibe and bile acid resins. They work in the gut, blocking cholesterol from being absorbed. Because of that, they can cause, you guessed it, diarrhea. And finally, niacin. It's famous for boosting that good HDL, but it has a very, very famous side effect, flushing. And here's that classic board tip. You can often prevent the flush by having the patient take an aspirin beforehand.
Okay, enough theory. We've learned the rules of the road. Now it's time to actually get behind the wheel. Let's apply everything we've just talked about to a clinical case and see how this all works in the real world.
So here's our patient. He's a 60-year-old guy. We look at his labs. His LDL is 130, and he's just been diagnosed with diabetes. And a key piece of information, no history of heart attacks or strokes.
So, looking at his whole picture, what is the single most appropriate step in management for this patient?
And the correct answer right out of the guidelines is to start him on a high-intensity statin.
Let's break down why. We can just run down our checklist. Is he between 40 and 75? Yep. Is his LDL between 70 and 189? Yup. And does he have diabetes? Yes, he does. He fits perfectly into Group 3. And for Group 3, what's the recommendation? A high-intensity statin. And of course, what's our immediate next step? We've got to order those baseline labs before he ever starts the medication.
And this really brings us to a final, really important question. You know, our case was pretty straightforward, but real life is rarely that clean. How do we balance these very clear guidelines with an individual patient's concerns, maybe their fears about side effects? And I think that conversation where the hard evidence meets empathy, well, that's where the real art of medicine happens. Thanks for watching.